I think we'll take some discussion. We'll split the discussion into two before we forget the questions we have. So starting by Dr. Ahmed Munir, you raised a very good point in preparing the patients preoperatively. The patients with red eye, a lot of patients, of glaucoma patients on topical medications, come in with very agitated conjunctiva. And I would like to ask the panels how they prepare them for filtering procedures, for bleb-based procedures.
Well, if it's a really inflamed eye, I like to give a steroid for a week prior to the surgery to just somehow cater to the subconjunctival inflammation so the bleb doesn't fail. And I agree, doxycycline is one of my favorites too. Sometimes it helps prepare the base pretty well and helps with the post-operative outcome.
For me, well, I completely agree. I also use a short pulse of steroids before the surgery, and usually our patients are old and they can get confused if we change suddenly the drops that they have to use. So in these cases, I stop all drops and like to switch to the oral Diamox for the first the week before surgery, so they don't get confused and the inflammation is controlled. The surface reach the surgery in a good situation.
Yeah, I think all the measures already mentioned. However, in some patients, just need to ask about if the patient has a systemic contraindication for the Diamox, because a significant number of 6-CPD deficiency, that they cannot do this. Other way, I also prefer to stop the prostaglandin analogs before the surgery, because it is already inducing a lot of inflammation. And as Dr. Mahmoud mentioned, we also add the doxycycline oral. This may help in controlling blepharitis.
Yes, also I stop the prostaglandin. I think I have to stop it and maybe replace it by a Diamox if the patient can take it. I think it's this is that I do it. Yeah.
Does anyone consider topical NSAIDs? There was a study that compared both in preparing the patients, and they might be less likely to induce some steroid response in patients who are responders.
So there is a worry, of course, about inducing a steroid spike. But we actually published a paper on this recently that giving FML for 2 weeks does not give you a steroid spike and actually prepares the conjunctiva very well.
So, any doctor?
Yeah.
I think I completely agree. It's all we share the same impression. The only thing I usually differentiate whether I'm dealing with a very urgent case or if this is like I have the pleasure of the time. And then, so if I have to operate within a week or so, and then the eye is very inflamed, I completely agree. I try to stop everything, just Diamox. And I found giving the mix between dexamethasone and lidocaine on the slit lamp, where I'm planning to do the procedure slightly above, obviously not the exact area, it always works very quickly compared with others. Especially if you don't have preservative-free eye drop. Like, for example, in Qatar, we don't have preservative-free eye drops, and that's an issue. But if I have the luxury of time, then definitely no need. Then I even add sometimes cyclosporine, which can even give more, especially if this is a high risk for failure, like Afro-Caribbean, young, myopic, these kind of things. But yeah, it depends.
Okay. Thank you very much. So, for the second talk, Dr. Anouar Fioumi, you covered very nicely the combined procedures. Now, I'd like to ask the panel as well and yourself, when do you combine an angle closure glaucoma? What is your, when you have a patient, we know that phacoemulsification is sufficient in a lot of cases of angle closure glaucoma. When do you decide to combine with phacoemulsification to do a trabeculectomy or whatever glaucoma surgery in the setup of angle closure?
Yeah, usually I don't combine it. I only do the cataract first. Then, if it's insufficient, maybe I will do later trabeculectomy.
Okay, so you split both. That. Yeah, that's very wise. Does anyone disagree?
Yeah, sometimes if it has a chronic angle closure glaucoma, just doing the cataract is not enough to control the pressure. So in this situation, I do combining. I resume with goniosynovitis, I go with the tube even. So it depends on the situation, definitely. Yeah.
Yes.
So
Dr. Shamira?
in Singapore, we have the highest rates of phacotrabeculectomy in the world. We recently published our 10-year series of an average of 10 years follow-up of our phacotrabs. And the worry was, of course, that the phaco would give you prolonged inflammation and the trab would fail in the long term. But we actually showed that we have developed a system where we actually can mitigate against those problems. And for the patient, there are several other advantages. Only one surgery done at one time. The costs are different, are lesser than the cost of the two individual operations put together. And that we know especially in our angle closure eyes in Singapore, the lens plays a very significant part in the pathogenesis of the disease. Hence, removing that actually works very well. So we kind of put it to ourselves that we rarely ever do just plain phaco. We would rather do the phaco trab, especially when we think, can I really be safe by just doing the phaco and not be having to do a trab very much soon afterwards?
I think we can add also iris plateau cases when the pressure is high, uncontrolled, peripheral endo to be done, and there is a significant cataract. I think a combined procedure for these cases can help.
Okay, does stage of glaucoma matter in the choice of surgery and the decision whether to combine or not?
So more recently, we've been having a lot of evidence come out from China of phaco GSL plus goniotomy, which works extremely well as well from Professor Xulan Zhang. So that may be an area to watch for this. But those would be the ones that would be a bit more milder, to answer your question. And the ones that are more severe would be the ones that would get the phaco trabs for sure, or on lots of drops.
Okay. Now, our last speaker, Dr. Baitzel. Now, I'd like to ask you and the panel as well, where does PreserFlow fit into your practice at the moment? If you have hold of it, it's not available in Egypt yet, but I have an idea. I've made up my mind.
I think PreserFlow now doing well with us. Now we are using it here since 5 years. As it's affordable, I mean the patient can pay. It's not covered by insurance. So if the patient willing to pay, it's my first choice now. For open angle glaucoma, for secondary glaucoma, now I'm encouraging to do it for more advanced cases. I did it for high myop patients, post-vitrectomy, and for ophthalmos eyes. There is some videos, but unfortunately we don't have time. Can I show you some tricks in the surgery for these high-risk cases, how to use PreserFlow with them, and how we can find results post-op without complications and with a good control for the pressure.